Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
It's Friday, February 14th, Valentine's Day. Hello and welcome to The View on GU. I'm your host, Dr. Aly-Khan Lalani, joined by my co-host, Dr. Christopher Wallis. Chris, we are so back. How are you, buddy?
Oh my God. This is where we're meant to be. It's Valentine's. It's San Francisco. I'm spending it with you, my friend.
Yeah, it's great. Day one at GU ASCO 2025. Just wanted to give a quick shout out because it's also our 1 year anniversary in a way of The View on GU, and wanted to thank all of our listeners and viewers, all of our supporters. We've had so much interaction in the hallways today and on social media, and we couldn't have been here without you. So thank you to all of you really who have listened and provided feedback and support. It means a lot to us and it gives us the fuel to keep going. Chris, how are you feeling?
Oh, it's great. It's been a really wonderful year. I think kind of blew our expectations away a bit. We've had great engagement. We've had, lots of listeners, lots of people interested in joining and participating in the podcast. And I think we've had a reach beyond what we expected to. So we've got another great year coming, and I'm looking forward to all we've got on the schedule.
Yeah, lots to come, and we'll tease that kind of as we go throughout the year. But this is high yield GU ASCO stuff, prostate day. So just to frame how we're going to cover what was day one of GU ASCO 2025, we'll start in the localized setting. We'll kind of transition to a little bit of data in MCSPC, really big OS data in MCRPC, and hopefully a potpourri as we go along the way.
Absolutely.
So Chris, why don't we start with localized, and just to frame it, as we heard in the oral session, really important work that was done, looking at understanding firstly, the age-old question of when we do radiation, when we do surgery in prostate cancer. Maybe take us through that, and really pleased to see you're involved as well in this abstract. So maybe take us through the individual patient data from the two phase 3 randomized trials.
Yeah, so this is one of the things I have to say I love about ASCO GU. It makes it one of my favorite meetings, is the whole multidisciplinary nature, right? We get our little silos at our urology meetings, the med-onc meetings, and here we really have a great mixing, I think, across specialties. And so you can see that even in the oral sessions, we have good urology representation, we have good radiation oncology representation, and we obviously have the stalwart medical oncology. So we started off the first two presentations heavy in the localized space. The second presented, but I would say when we think of disease treatment pathways, the first decision-making in the context of high-risk localized disease. And just to reiterate, this is NCCN criteria. We're talking Gleason scores 8 or greater. We're talking PSAs of 20. We're talking clinical T3 disease. The question really is, how do we best treat these patients? There's obviously a backbone of localized therapy, and that comes into that, forever debate about, should we do surgery? Should we do radiation? I think we could talk more about the details of this question, but fundamentally, high-risk disease is a systemic relapse problem more than a local relapse problem. And that's, I think, how we need to frame a lot of the thinking. And we'll talk about the trials that went into this analysis, but we really need to think about the systemic backbone probably being the key here. And we need to provide some local consolidation, but that's arguably secondary. So in any case, we've had for decades probably analyses of debatable quality trying to compare surgery and radiation. We have population-based analyses using administrative data sets. We have single institutional cohorts, or multi-institutional, where people are pooling their studies or their patients into a study. And the trouble always is multi-level, right? We have data quality issues, we have comparability issues, we have confounding issues, and so in this analysis, I would say we can address some, but not all of those problems. So the authors and I, for full disclosure, M1, pulled two sort of contemporaneously running randomized trials. So the CALGB 90203, also known as PUNCH, looked at the role of perioperative ADT and docetaxel in a surgically treated patient population, and RTOG 0521 looked at the role of adding perioperative docetaxel to a backbone of radiation with long-term ADT. And so the idea was that you could compare across these studies because they're both phase 3 trials conducted at the same time. But it's important to remember that these studies were conducted completely independent of each other.
Yep.
These patient cohorts do not interact or cross in any way. And so we've grabbed an arm from one study and an arm from another study, and we're comparing them. So while the data is quite granular, it has all the benefits of a clinical trial cohort, this is clearly non-randomized data.
Yep.
So what we see, interestingly, the primary outcome is MFS. In the overall analysis, the patients treated with radiation, i.e. those in the RTOG cohort, fared better than those in the punch cohort. And so, the difference in distant metastasis rate at 8 years is somewhere in the range of like 6 or 7% absolute, 23 versus 16%. The more you account for systemic therapy, the less the difference becomes. And so when you look at those like surgery-only patients in the punch cohort and you tease those out, given that there's 3 years of ADT in the minimum in the radiation cohort, the more you give standard systemic therapies, the less difference you see. And so I think as we look to the future, we're thinking not just ADT as a backbone, but novel hormonal therapies and ARPIs. Docetaxel is kind of, even in the metastatic setting, not showing a ton of benefit in that low volume patient population. And we can really think of this as an ultra low volume, right? We're worried about distant failure, but they don't probably have it yet. So docetaxel, probably not the intensification we want, but we've got Atlas and Proteus probably reading out.
Yeah.
Maybe the next time we summarize big data, and many more studies coming in that vein. And so while I think it's interesting and it's important, it's not going to be the make or break here. And I think we really need to focus as localized disease treaters on that systemic intensification in this high-risk patient population more than we fuss about whether to operate or to radiate.
Yeah, and I think, as you said, right, these are often patients maybe seen in multi-D clinics or discussed at tumor board, and I don't know that anything has changed the standard, but as you say, we got to think in the future that, already very high risk localized is getting the chance at abiraterone. At this point, there'll be more to come. And as you mentioned, we might even have pills pre and post of surgery. So I think as we get that systemic therapy, it'll be important. So let's stay and pivot to the next abstract, but stay on radiation. And obviously there's definitive radiation we can deliver. There's radiation at the time of biochemical recurrence. We always wonder, how can we look at, dose response or predict that? And there was this interesting, validation of the Porto signature in a couple of phase 3 trials. So why don't you take us through that? What do we learn and kind of where do we go, especially given that radiation has evolved itself?
For sure. So Portos, I think I really loved seeing this year. Portos was originally published in a nice Lancet Onc paper back in 2016. And then it kind of fell off the map. And it's sort of been ruminating in the back of my mind, like, what happened? This seems like it's such a useful thing. So when it was originally developed, the concept was around postoperative radiotherapy, hence the name. And the idea was that a low Porto score was a genetic signature, genomic signature indicating probably less benefit or no benefit to the addition of postoperative radiotherapy, whereas a higher Porto score would indicate that a patient was likely to benefit from the addition of radiotherapy. And so, I think this is nice because in localized disease, we have to weigh this decision-making around adding therapy escalation, but also de-intensifying therapy and de-escalation, because fundamentally the oncologic outcomes are quite good. And we, in localized disease, really have to think about the harms of our therapy and are we doing too much? And so the authors in this analysis did 2 parallel studies. The first was really a validation of that initial postoperative setting. And so they used the SAC 0910 trial, which was a post-op intensification or dose escalation study, 64 gray versus 70 gray. And they showed that if you had a low Porto score, dose escalation, i.e. giving more radiotherapy in the post-op setting, did not add benefit. Whereas if you had a higher Porto score, you did derive benefit. And the improvement here is meaningful. The hazard ratio is 0.12. There's like an 80% improvement. So this is a big magnitude of effect. And then I think interestingly, they performed in a parallel cohort, but in a similar clinical context, some biologic correlates, really showing that it appears that it's an association with hypoxia and immune-related infiltration that is correlating with a Portos score rather than standard clinical pathologic variables, giving us an idea that maybe these are actionable aspects for these patients who have higher Porto scores. So we can maybe use this not just as prognostic, but maybe even predictive. And then the same analysis is essentially undertaken in the definitive radiotherapy setting. So this was the RTOG 0126, and really the same question, a dose intensification study going from 70 to 79 gray. And again, we see that in a low Porto score patient population, There's no benefit to dose intensification. Intermediate gives you a small magnitude of benefit, higher POTAR score, larger benefit. So this is really a nice potential tool to allow us to decide on the patients who need more therapy versus less therapy, really, moving us from our blanket intensification context today to a more targeted approach where we can really intensify only those patients who need it. And I think as we wrap that's probably where our localized treaters lose the real edge. And now we're thinking more about systemic disease in the rest of our presentations. And so obviously the next step in our progression of disease is going to be into the MCSPC space. I would say there's not big primary data that came out here at this meeting, but there's some really nice summary data, meta-analyses, and integrative approaches that may help guide us in how we do drug selection and patient selection.
Yeah, I mean, I agree. I think the stopgap meta-analysis was interesting. So this was, looking at, pairwise meta-analysis of individual participant data from completed trials. So this, really had a lot of, I think, available patients for analysis, looking at overall survival, progression-free survival, even prostate cancer-specific survival. And really, there was 11 ARPI trials that were eligible. They ultimately used 7. And so this had a lot of the typical trials, right? Stampede, Latitude, and Peace 1 for abiraterone, Enzamet for enzalutamide, Titan for apalutamide, even having Stampede for the combo of APA, Enza. And I think, many years of follow-up, I think what was really important is that we saw, as we probably suspected when we looked at individual trials, that the benefit on survival for men with MCSPC is clearly in the 0.66 range, just reinforces what I think is a global standard of care. And to have that absolute improvement of 13% at 5 years was interesting. I think what we've tried to understand, and again, admittedly, this doesn't answer the triplet question yet, but I think what we've tried to understand in clinic is how do we make choices, and that wasn't necessarily the point of this analysis. But I do think one thing that stood out for me is a little bit of the age effect. And, the authors were able to look at an age group of less than 65, 65 to just under 75, and then 75 plus. Now, key thing here is for overall survival, the benefits were maintained, certainly in the cohort under the age of 75. Even in those over 75, when you pull all this together, the hazard ratio overall was 0.77. And so, that is important to see. But when you tease down a little bit more, I think that's where it became interesting that in the abiraterone trials, so when you separate from the other type of class of drugs, again, those under the age of 75 in whatever cohort bin really benefited. But there was that drift in 75 and beyond. And so it makes you think that as that hazard ratio got really closer to 1 in terms of overall survival, although prostate cancer-specific survival in the age over 75 was still a hazard ratio of 0.77, it makes you think that it's still working, it's benefiting these men, but for a variety of reasons, which probably need a little bit more granularity. But in actual fact, I think we can speculate that at least while the PCSS is reduced, there is something happening in these men with the potential of abiraterone where they are experiencing an OS event that really puts that hazard ratio of 1.01 when you look at control arms in that trial. So it makes you wonder, a competing risk of death for that age, certainly, but that would be expected in both arms. So now you wonder if there's a treatment that is potentially having some sort of deleterious effect in some way. Abiraterone by definition needs prednisone. These men are living a lot longer. Now we're having a lot longer prednisone use than expected. So it's not to have a biological explanation off the hop, but I think it did create some questions around, which drug would we be using in men over the age of 75. And I certainly think it's fairly common sense to try and see if everything else is equal to avoid a prednisone employing agent, balancing the fact of drug-drug interaction. So I thought from a, very quick MCSPC review of all the trials we've had, there is something to be said about the age group. And, certainly they'll be, looking at building on this, right? This is the first kind of meta-analysis of individual data from our ARPI trials, and probably more to come.
Yeah. And I have to confess, from my simple urology mind, going back to older, maybe experience with these drugs, I always worried in the older men who are maybe a little less robust that the fatigue from Enza would wipe them out. And so I had originally thought of maybe abipred as a preferable regime in this older, frailer population. And this cohort, this analysis is maybe suggesting that my initial instincts are not so reliable, and I need to readjust my my orientation to the landscape. I think we saw a little bit of other data in MCSPC that we should highlight. You and Mike Ong did some interesting work sort of digging into ARSN, speaking of ways that we can intensify therapy, and maybe walk us through that.
Yeah, no, this was a really enjoyable endeavor. So ARSNs was a large randomized phase 3 trial, and many of us had clinical questions, and it was a really nice way to show that I think investigators, and in this case, myself and my colleague in Ottawa, to be able to, go to a large company and ask an important clinical question, which was simply the use of GCSF in these patients, in these trials. Why and what was going on? What's the use? What does it look like? Because we notice a disparity when you use docetaxel in prostate cancer. There is disparity globally. Some folks will say we mandate GCSF in all of our patients. Some people commented that it was used maybe in the COVID era and less so now. And some more likely dogmatically employ it as a secondary prophylaxis approach. And so we were able to work with the ARSN's clinical trial team to really understand this better. And so what we dug in was the relative dose intensity of docetaxel throughout the study. We saw that about 43% of men in an MCSPC trial, again, being very fit for a clinical trial, still needed GCSF. Largely, this was all secondary prophylaxis. But, it does give you some caution. We were able to get into the granularity of Asia having higher use than other, North American, rest of the world experience. So there's something biologically there. I mean, our colleagues in Asian countries, Japan and others, are very interested in this data. And it did make you think that we saw how much relative dose intensity occurred. And so the more dose intensity, obviously, better the outcome. GCSF helps support that, but we were able to comment on dose reduction pieces. And as we get beyond this poster into the manuscript, we've met with the kind of ARSN's team today. And we're going to try and dig into what was the reason. Was it simply neutropenia? Was there actually experiences of a grade 3 or higher adverse event? So I think it was a nice story to be able to have, two Canadian treaters and curious researchers to say, hey, I wonder if we can answer this with a phase 3 trial. I have to give shout out to the Bayer team that did support us in asking this and delivering. And now we're going to have a manuscript from that. So that was kind of our contribution in the MCSPC space.
That's awesome. I think the last thing as we transition to some of the big data in MCRPC, we saw a little update from the Stampede group around transdermal estrogen. I think it's, an interesting idea as a different way to provide androgen deprivation. This analysis really showed, building on their ESMO analysis, that you can use transdermal estrogen in combination with ARPIs. So if you're wanting to intensify your patient, that doesn't preclude you from taking this approach. I don't think it's very widespread in our communities yet, but certainly can be something to consider. You're obviously trading a little bit of gynecomastia for some more manageable hot flushing. So there's certain balances and trade-offs to be made. But I think, having more tools in our toolbox never puts us behind the 8 ball. So in that context, let's transition to arguably the biggest data from the meeting in prostate, which is the OS update from TALAPRO-2. You want to walk us through both a podium presentation and a poster that I think are complementary?
Yeah, totally complementary and certainly exciting to see. So TALAPRO-2, just to recap, this was a first-line MCRPC trial. These were essentially patients who were randomized to placebo plus enzalutamide and talazoparib versus enzalutamide in the interventional arm. Now, importantly, there was initially a recruitment of an unselected cohort, meaning those that were non-deficient or unknown. And then there was an HRR altered cohort, which was a cohort 2. And the aim here was to try and report on a final pre-specified overall survival. So, in this large trial, the primary endpoint of rPFS was really maintained, and seeing a median of 33.1 months in the talazoparib plus enza arm, which I'll call tala arm, versus a placebo arm with enzalutamide of 19.5 months. The big thing was a overall survival final analysis showed that the Tala arm had a survival of roughly 46 months versus 37 months in the Enza arm, really behaving exactly like the Prevail trial did. So that was interesting to see. Now, that hazard ratio of 0.8 needs to be contextualized, and this is where it gets a little bit more granular. So the deficient population, so those patients that were HR altered, had a hazard ratio of 0.54. Those who are non-deficient or unknown, which are the majority, that hazard ratio of 0.874. So that was, I think, causing, I think, admittedly, lots of discussion because there was, that companion kind of data from those who were altered, and that was actually a poster. And, really interestingly, it showed that in those patients who had the HR alteration, that, any HR gene alteration was found to have, an overall survival benefit in the order of a hazard ratio of 0.62. When you look at BRCA1, 2, unsurprisingly, that hazard ratio drifted down to, 0.497, so 0.5, let's say. And those that were non-BRCA1, 2, but still had HR alterations, that current hazard ratio is in the 0.73 range with the confidence interval of the cross is 1. So, when you step back and look at all of this together, we know we've had Propel, which looked at, really having olaparib as the backbone of your PARP with abiraterone. We've had Magnitude, employing niraparib. All these trials are slightly differently designed, prospectively defined of the alteration or not. And thus far, largely what we've seen is the world has felt that, certainly from and again, this is where it gets complicated because around the world, it's all very different as well. So in the US FDA, the olaparib, Abi combinations for BRCA1, 2, the niraparib, abiraterone is BRCA1, 2. Talazoparib has more HRR alteration. In Europe, the Abi olaparib is all comers where chemotherapy is not an option. Same thing with Talapro. And then niraparib is for BRCA1, 2. And for those in Canada, again, largely we have seen the reimbursement of these. So it's different than Health Canada label, but the reimbursement of these largely in the BRCA1, 2. And we are now going to see with the Health Canada label in Talapro of HR altered, we're going to have to see where reimbursement has. So, I think lots that we could talk about, and, we want to be mindful of time here, but I think it's still my takeaway. We still need to up our ante in how we do genomic testing. I think we're getting better at so-called mainstreaming germline testing. I think it's really important that thus far we're doing somatic tissue testing, and there are challenges with that. Retrieving the tissue, having an actual accessible result, this can vary. We need to be able to do this because personally, I would like to see a future state of where we're using blood, if it's through ctDNA or other, but essentially using blood to try and find out these alterations. And it'd be really cool if we could use blood to assess and separate germline and somatic. So I don't think we lose the genomic game here just because we have an overall survival that technically includes all comers. I think the world is going to have to grapple with this. I think it's very true that the BRCA1, 2 across all these trials seem to have the biggest magnitude. Even within the BRCA, we see differences. So, really at the end of the day, I think this was really important to see. It is likely that we're going to have a little bit more broadening of which patients with HR alterations can get it. And I'll just make a quick editorial here that I do think having a little bit of broadening, if we could get this for all HR altered patients, might allow us that in men who, for example, look like maybe a little bit younger, you're worried that even the testing might miss an alteration because it's only based on what we can test right now, that maybe you'd like to have a combination that you could go to here. So, this is going to add another tool in the armament. It makes it complicated, but certainly that's, I think, a high important thing to highlight. Just as we're coming up to the end of the podcast, it's funny how time flies. Chris, anything last little potpourri? We saw some cool things out there that you wanted to highlight at the end.
Yeah, I think we should give a little Canadian love. I think there's a couple of Canadians on the podium, and I think it's worthwhile to always acknowledge those. We have some really strong showings from Montreal. We got great data showing that testosterone recovery after either 18 months or 36 months of ADT with concurrent radiotherapy is importantly prognostic for OS. So we know that not all patients recover it. In fact, maybe like 50% will not after a relatively long durations of ADT. But those who do fare much better. So it's an important thing for us to think of the holistic care of our patients. And then the other sort of big contribution, I would say, from Canada and again from Montreal, PCSS9. So this is the role of MDT, metastasis-directed therapy, in oligometastatic mCRPC. So this is, I think, a great contribution from Canada. So the role here, this was designed to be phase 2, 3. As the trial accrues, obviously ARPIs become more standard of care in mCSPC, and the rationale becomes a little bit harder to justify. So we cut here around 100 patients, first-line mCRPC, randomization to a systemic backbone, Enza ADT, or the addition of SBRT. And really importantly, we're seeing meaningful benefits. RPFS hazard ratios around 0.5. We're seeing absolute benefits in the range of 2 to 2.3 years in RPFS. We're seeing OS hazard ratios now not significant, but 0.71, going in the right direction, which is really impressive given a relatively small phase 2 study to see OS heading in that direction. Yeah. So I think that's really a great contribution, and put in a greater context. There was a nice meta-analysis of the use of metastasis-directed therapy. It's called the Wolverine study, the XMET Collaborative. I think
love that name.
Across the board, we're seeing benefits of the use of metastasis-directed therapy. So this is all randomized data across various states of oligometastatic prostate cancer. And they did both trial level and individual patient data analyses, showing something in the range of a 55% PFS benefit, hazard ratios around 0.45, and an OS benefit in the range of about 35%. That's a hazard ratio of 0.66. It's pretty similar to what we just said systemic intensification with an ARPI offers in mCSPC. So clearly, again, the role for an MDT context for these patients needing multidisciplinary input, the role for radiotherapy to really contribute to tumor site control, which can augment the benefits we get from our systemic intensification. But I do think historically MDT was used to avoid systemic intensification. I don't think that's how we should interpret these data. This is not one or the other. This is add MDT to a solid intensified systemic backbone.
I totally agree. And we're going to see this more and more. I mean, you and I know, right? We sit in these tumor boards and we're getting so-called localized patients, getting a PSMA PET, boom, other lesions. We review. What are we leveraging? What's the definitive management? Can we put SBRT and systemic therapy together? And I agree with you. I would prefer in these patients, even so-called volume status defined by novel imaging, I would prefer to start with upfront kind of the systemic and or SBRT in centers that have that expertise. And then pending response, I think the question becomes, in these potentially classically low volume patients, could we step back a bit on something later, as opposed to just leveraging SBRT and meaning missing that systemic therapy, which clearly is a life-prolonging benefit. So it's super cool. It's more to come, and it's exactly why, frankly, we did this podcast as we think about a year later, is because we have these conversations, and it's really nice to have this data.
Absolutely.
I think it's important that we have it, and hopefully more to come.
Absolutely. I think it really highlights the value of a meeting like ASCO GU and the podcast we've got with that multidisciplinary input. We get a real representation of the data in the same way that we want to practice, which is bringing everyone's expertise to the table to really leverage all of our knowledge, all of our skills to get the best outcome we can for our patients. With that, I think we should close up Prostate Cancer Day.
Good day.
Day one of ASCO GU. I want to thank everyone for joining. I hope it's been interesting, been valuable. I want you to like, review, subscribe, follow along with us on all of the social channels, and we'll see you for episode 2, ASCO GU, bladder cancer.